Welcome today to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, and I'm the Educational Programs Coordinator for the Focus. And here today is going to be Cherie Binns, an MS certified registered nurse, as she is every other month. She does this for us. She's going to be answering as many of your questions as she can, and we would love to introduce her. She is an MS certified registered nurse and is also the patient healthcare liaison for MS Focus. She was diagnosed with relapsing remitting MS in 1994 and has found that adopting some changes in her lifestyle has made her MS much easier to manage. Cherie, we are so thrilled that you're here again, as you are. You do so much for us, but we love when you answer all these questions. So why don't we see if there's anybody who's put anything in yet?
Well, I don't see anything in the Q&A, but
No?
I also moderate our Facebook groups, and somebody just before lunch today posted something about being on Ocrevus and having increasing trouble walking over the last year, and her neurologist suggested that she get a walker. And so she was asking the group what were the best walkers to try. Whenever something like this happens, the difficulty walking is generally because we have become so immobile. We're basically we don't feel wonderful, so we're not doing as much moving. And the more moving we do, the better our walking becomes. If you're having a decline in your walking speed or power, you really need to be seeing a physical therapist, um, because a walker might not be the right or the safest mobility aid for you, and they can tell you what works for you.
Wonderful. By the way, for anybody that hasn't been here with us before, if you have a question or a comment, you can ask it using the Q&A button in the app. That also allows you to send your question anonymously if you like. We're going to ask that everyone keep their questions to just the Q&A and not in the chat area. So if you do that, also if you're on the phone and you'd like to ask a question, you just hit *9 and we'll call on you and you'll unmute and it'll work. So let's see
And
here.
if you're watching us in the Facebook live stream, just put your questions in the comment section, and we've got somebody behind the scenes who will pull that and put it into the chat for me. That's what we're saving the chat for.
Yep, here. Is there any special tests needed before starting Mavenclad?
Yes, Mavenclad does change the way we make our red blood cells, and also our white blood cells. So we do need complete blood counts, and you'll be getting complete blood counts about a month, but a couple of weeks before your first dose, and about a month after your second course. So each year you take a week's worth of pills. So it's 5 days of pills in 1 week, um, followed by a month later, 5 days worth of pills again. After that second month, you're going to be having a blood test again, very similar to the one you had prior to going on the Mavenclad. You do the same for second year as well. So the only real blood tests that are absolutely necessary are the complete blood counts.
Thank you. And Ben would like to know if tinnitus is a symptom of MS. And also, with the updated McDonald criteria, do you think some people will want to get re-diagnosed?
Um, Tinnitus can be a symptom of MS. If it's accompanied by vertigo, I don't mean just lightheadedness. I mean, like literally, the room is spinning. A physical therapist may be able to do a procedure by changing the movement positions of your head so that it readjusts the crystals in your inner ear, and that can help. But the ringing in the ears can be a symptom of MS. But it also can be caused by a number of other things. So that needs to be worked up, preferably by an ear, nose, and throat doctor or even an audiologist.
Okay. And as far as the McDonald criteria,
Oh, as far as the McDonald criteria, um, Dr. Boster was asked that question right after the updated McDonald criteria were made available. And he was very adamant that if you've been diagnosed under the 2017 criteria, you won't have to be re-diagnosed. That said, when the criteria was updated in 2017, approximately 25% of people that had been diagnosed prior to the 2010 updates to the criteria were actually undiagnosed. So if you have an atypical presentation of it, if you haven't been having regular relapses, um, it is possible that your neurologist might want to do a couple more tests to make sure that the diagnosis was in fact accurate. I wouldn't necessarily bring it up to them unless you believe that there may have been an error in the diagnosis. I know I've spoken to a number of people lately who have said that other than some dizziness or some left-sided weakness, like 12 years ago, they've never had another symptom of MS. They were started on medication, stayed on it for a couple of years, didn't notice any difference, so they went off of it. They've never had problems. If that sounds familiar to you, it may be a conversation you want to have with your doctor, so as not to expose you to medication unnecessarily or costly tests like MRIs. So, yeah, I would think that if you fit that criteria where it was a one and done, you never had any more um, MS activity, it's not uh, manifesting itself to you in any way, have that conversation and they may be able to help you get undiagnosed if that is in fact reasonable.
thank you. While we're waiting for some questions, I just thought of something. Can you, for those people that are not familiar with our Facebook group, the one that has thousands of people, can you tell them some of the benefits of that group?
Yeah, we have a public Facebook page to which this webinar is being streamed, but we also have a private page. You have to answer membership questions to get into that page. It is for people in the diagnostic process or their families, or their significant others. It's for people that are diagnosed. Oh, it's for care partners as well. So basically, the questions are whether or what is your reason for wanting to join this group, and you can just say something to the effect of in the process of being diagnosed, or I think I might have MS, or I have an MS diagnosis. There's just a couple of questions to answer like that. We also have a couple of other groups that are private groups if you might fit into those. There is an MS Care Partners only private Facebook page, and even people that have MS cannot be part of that page. Unless, of course, you're like Dan and Jennifer and you're a married couple and you both have MS, but you're care partners for each other. I mean, there are exceptions that can be made. But as a rule, we like the care partners to be able to speak amongst themselves without any fear of judgment by somebody who's living with MS as to not understanding why they're asking the question they are. And it's, it's a good place to get that kind of support. We also have a private Facebook page called MS Focus Confidential, and that is only for people living with MS. You cannot invite people to look at that site. You cannot have your significant other come onto that site. So nobody without MS belongs on that page. And our most recent group was started about a year and a half ago, the MS Focus on the LGBTQIA plus community. And that is only for individuals who are members of that community and either living with MS or caring for a person with MS.
Thank you. Thank you. So Karen says that she's on Kesimpta and she has to have surgery. Should she request antibiotics?
No.
Okay.
No, you do have a little bit greater risk of infection, particularly airborne infections like colds, the flu, COVID, that sort of thing. In some people, you have a little bit greater risk of urinary tract infections when you're on that class of drugs. But the OR is a pretty safe place as far as that's concerned. You're well prepped with antiseptic um, pre-showers with a local antiseptic cleanser prior to the surgery. So we're not worried about wound infections in cases like that. We're not worried about airborne infections. So no, you don't want an antibiotic. If you've got something like a hip replacement or something like that, they may put you prophylactically on an antibiotic, particularly if you've got if the wound is becoming inflamed, but you don't want to request that prior to.
Thank you. You might need to help me on this one. Julie is saying that she keeps watching the progress with the use of pulsed electromagnetic field therapy for, I can't pronounce that name,
Synesthesia, specifically
specifically.
persistent burning pain. Um, uh, the pulsed electric magnetic field therapy is we're seeing with some people that it seems to help. It's certainly not a panacea. It doesn't help everybody. It probably isn't going to hurt you, but uh, I would check with a physical therapist who commonly uses that kind of therapy, or a chiropractor who uses that kind of therapy, and let them get to know your body a little bit and see how it responds to it and tell you what settings to use.
Okay. And the allodynia, is that
That's
similar?
that's a loss of sensation. Yep,
Okay.
yep.
Thank you. Joe Mary says, would you please explain bladder issues with MS? I say I have a nervous bladder. I know that I need to empty my bladder, but I feel like I can't relax enough to go. Sometimes I go back and forth to the bathroom several times before I can finally go. Thank you for any information you can share.
There are two fairly common presentations of bladder problems with MS, and they're both related to the nerves going to the pelvis, the bladder, the bowel, the sexual organs being impacted generally by lesions. It could also be from a lesion in the brain that affects that area. So the most common way that you're going to see is an overactive bladder or a small bladder. Our bladders generally hold about a cup of liquid before we feel like we've got to go to the bathroom. People with that hyperactive bladder may only have 60 to 100 cc's instead of the 250 cc's that are in a cup. And so they've got this real urge to go, and sometimes it's like really urgent, and they may not be able to make it to the bathroom in time before things let go. The other presentation is an inability to empty the bladder, oftentimes because there's a spasm at the top of the urethra where it connects to the bladder. The urethra is the outflow from the bladder. And oftentimes there's a spasm there that just doesn't want to let go. Both of those do respond oftentimes to medication, uh, but a bowel and bladder therapist may be able to help you as well. I think, given what you're telling me, Joe Marie, You probably need to see a urologist and get some bladder studies done. They're going to take a look at your bladder through an ultrasound to see if once you've emptied your bladder, there's still urine left in it. That means that you're not fully emptying. And so 15 minutes later, you feel like you've got to go again. Um, that kind of sounds like it to me. And if you're not fully emptying your bladder, there are a number of things that can be done. There may be a medication that will relax that spasm in the at the top of the urethra, and kind of let the bladder empty. Sometimes you're going to need to change the way that you go to the bathroom. You may need to just sit there, take some deep breaths, and just let everything relax. Concentrate on what's down there and relaxing the muscles, and um, even sitting there for a couple of minutes and trying again before you get up to make sure that more empties. So the place to start with something like this really would be a urologist so that we know exactly what's causing this. Do you have too small a bladder, or do you have a bladder that's gotten so large you're emptying it, but you're really not emptying it. You feel like you're emptying it, but there's still urine left in the bladder. And both of those are things that need to be addressed and corrected. I will say that for people that have an underactive bladder, where they're not emptying fully, even though they might be going frequently, oftentimes intermittent self-catheterization is a way to really address that. Catheters are very small for women. They're the length of the urethra. So a woman's urethra is about an inch and a half to 2 inches long. And so the catheter is only about 3 inches long. And you just pop that in and it empties your bladder pretty fully. It's very simple to do. There's only 3 holes down there, and we know that urine comes out of one hole, and stool comes out of another, and something else goes into another. So
Mm.
you pretty much know your anatomy if you know what comes out and what goes in which places. So that's something very easy to do. I have catheterized myself off and on for years. Fortunately, that's not a lifetime thing necessarily. Once I've gotten over a relapse, I often had never had to catheterize until another relapse came. And on the more effective medications that we have today, I'm not having relapses and haven't had that problem in about 10 years.
Sherry, if somebody that was having these problems went to their urologist and was going to prescribe the catheter process, would they also give them a little tutorial on how to do it so that when they leave, they know how to do it, or do they just send it home with them?
They wouldn't have the catheters to send home with them, but yes, they do have handouts to show you how to do it. And when you get your catheters in the mail, there's usually a pictorial a tutorial or even a YouTube video that they'll send you a link to learn that. Um, Maybe you'll even get a referral to have a visiting nurse come out and help you with it the first couple of times, just to familiarize you with the process.
Thank you. So we have someone asking if they were diagnosed with MS after receiving a flu vaccine. Have you ever heard of any symptoms prior to receiving? Okay, they never had symptoms prior to receiving the vaccine, and they're wondering, is it possible that the flu vaccine triggered the MS?
That's a pretty common question. The flu vaccine is specifically designed to create an immune response so that you don't get the flu. It can feel like you've got the flu if you really have a strong response to the flu vaccine. And that, if you already have MS, You might not even know that you've had it. That can cause things like optic neuritis, so loss of vision in one of your eyes, or increased spasticity or weakness on one side of the body. Those are the most common ways that MS presents itself the first time. I do not believe the flu vaccine causes MS, but it certainly can trigger MS symptoms that are dormant.
Hmm, interesting. So, if you remember Julie's question, she said she's sorry for the confusion, but for allodynia, she was referring to light touch being felt as pain.
Yeah, I'm not sure your pulsed therapies would help with that, although um, I have a spot on my lower leg that is like that. If the wind is blowing across it, it will create this intense instant pain. When it first started happening about 10 years ago, it used to almost bring me to my knees. It was so intense. Um, what they suggested that I do was to get a TENS unit and put a pad above the area and a pad below the area to sort of distract that area from the sensation. I found that for me personally, that actually made the sensation more intense rather than distracting it and taking my mind off of it. So, again, this is something that probably your chiropractor or your physical therapist would be best able to answer for you and tailor a program with it if they felt that it was reasonable for you to work with that. The closest thing we currently have right now is TENS units, and you can get a TENS unit um, for anywhere from 35 to $50 on up. Um, most medical surgical supply stores carry them. I know that CVS carries them. Um, Amazon has a number of different types of TENS units. And you really can't hurt yourself too much with those over-the-counter TENS units. So try it, see if you get any relief with it.
Thank you. I don't know if I'm pronouncing this wrong, but this person says that they were recently diagnosed with uveitis. It's in the left eye, the same eye that has optic neuritis, and they were on Tysabri for 3 years. Why didn't their DMT prevent this from happening?
I'm told that uveitis is not caused by MS. There are a number of causes of uveitis, but it is not MS related, so the DMT would not have stopped that. It can be caused by contamination. You've got something on your hand and it gets into your eye, much like a conjunctivitis or pink eye. So you could have gotten something in your eye, even microscopic. If you're a contact lens wearer, and you're not cleaning your lenses properly, or maybe your solution has expired, that also could trigger that. So ask your ophthalmologist about that, what they think it was the cause of the uveitis, but it is not an MS caused or MS related issue as optic neuritis is.
Thank you very much. Okay, if anybody has a question, please put it in the chat area. For all of you, because you probably don't know this, but Cherie, in addition to all the other things that she does, is training people, women. I think they're all women, right? Or no, maybe not. No, no, no. Forgive me. I know. She's training individuals that are registered nurses to become certified MS certified nurses. And I think that's pretty darn cool. So I wanted the
Um,
whole world to know.
there's about 1,300 of us worldwide that have that certification in MS nursing. Um, there's an exam given twice a year for that. You have to be an RN who's had at least 2 years of working with people who have MS to take the test. And the people that I'm just so blessed to work with right now are three individuals in this community who are all living with MS and they're all RNs. And I thought that I was one of the few until a few years ago. I was certified in 2003 and have kept that certification going. In order to keep that certification active, you need an average of 25 hours of continuing ed classes every single year. And it's renewed every 5 years with proof that you're getting regular education in MS care. And a lot of people, all the drug companies have their nurses in their call centers certified, but there's a lot of turnover in those, so those people don't recertify. Um, and even though maybe 40 people take it twice a year, the numbers are not really creeping way up there. There's just a handful of us that have gotten that certification and maintained it.
So, would you say the majority of nurses that are working with MS neurologists are not MS certified?
Or not.
They're not. Interesting.
Um, there aren't that many nurses working with MS neurologists. They're mostly medical assistants, and they'll do your history and your medications and your vital signs, but they're not actually nurses. I will say that there is another exam, another certification exam for people who are in the rehab arena that are OTs, speech therapists, physical therapists. Even I've seen some certified nursing assistants that have taken that exam and passed it because they're working maybe in a rehab facility where people who've had um, a really intense relapse happen where they've needed some rehab afterwards, and they're working with that kind of population all the time, and they are also certified. They're MS certified specialists. Um, Dr. Karpatkin is an MS certified specialist. We also have on our medical advisory board a speech therapist who is a certified therapist and a chiropractor. Um, so there are a few physicians who are actually certified as MS certified specialists, and some of them happen to be MS neurologists, but the majority of MS neurologists haven't gotten that certification.
And I know that Herb Karpatkin, he
Yep.
also teaches, he certifies his his students to be MS certified. Pretty cool.
Yeah, he and I were
Yeah.
sort of talking about the possibility of running classes together where I would work with nurses and he would work with physical therapists, occupational therapists, speech therapists, and get them ready to take the exams so that more and more people would have that certification and maybe be able to go out into more rural communities or areas that didn't have an MS center in them. And I know that some nurse practitioners are actually the only source of MS care in some of those rural areas.
Hmm, interesting. Julie said that related to the question about the flu vaccine, do we have any statistics on MS symptoms or progression being triggered by the COVID vaccine?
Again, the COVID vaccine can trigger your MS symptoms, but I think part of that, and I can say this from my own experience, I think after my third vaccine, this was back when we gave 2 shots to start with and then got a booster. Um, I had such a high fever that um, I really had a resumption of the worst of my MS symptoms for several days. That was not a relapse. That is what we call a pseudo relapse, only because there was a fever present. Any fever can do that, and many vaccines can raise your body temperature um, as you're building that vaccine response, whether it be the shingles vaccine, the RSV vaccine, the flu, or the COVID vaccines. Even a tetanus shot could do it for you. but it does not make the MS worse. Once the fever goes down, those symptoms taper off and go back into the background.
Hmm.
So, no, COVID vaccine does not make MS worse, but if you've got a fever, even a quarter of a degree elevation can cause some of those symptoms to resume in people. And once you cool back down, they just fade right away.
Hmm. Leslie said that her ophthalmologist said that uveitis is an autoimmune disease separate from MS.
It is. It's not caused by MS and it's not related to MS.
Good questions. So here we are. Let's see. Trying to think of a really good question to ask you.
I think this group might also benefit from, we started something new with the foundation recently, and that is that so much is becoming digitized that we are no longer printing our quarterly MS Focus magazine. It is available online. You can download it, you can print it out if you want something to hold and read. We will still be doing our March MS Awareness Month educational booklet in magazine format, and that will still be mailed to you if you were getting the magazines mailed to you. And then in the fall, we will be doing the year in review on what's new in MS treatment and care from the previous 12 months. So you're still going to get 2 instead of 5 issues mailed to your house, but you can go on to the msfocus.org and publications and MS Focus magazine and read that online or download it and print it out.
Mhm. And if the folks that are with us today happen to know somebody with MS that's not familiar with computers, because I did get a phone call today. Someone said, I don't even have a smartphone and I don't do computers. And I said, well, then somebody you love must know how to do that. So I suggested that they ask someone that cares about them to go to our website, print it out for them, and hand it to them. It'll be like having a magazine in their hands. So if you know someone like, obviously everyone here today knows about computers or phones because they're on this webinar. But if you know someone, that would be a nice little tidbit to tell them, just as a suggestion. Um, so do you recommend the flu vaccine for someone diagnosed with MS? This is by Lisa.
Absolutely. I think all of us with MS should be getting our flu vaccine, our COVID vaccine every single year. If you're over 60, and particularly if you're on one of the B cell depletion medications like Ocrevus, Kesimpta, Rituxan, Briumvi, or if you've been on Lemtrada recently, particularly, if you're still immunocompromised by that, you need every protection possible to keep from getting a flu or a COVID that will land you in the hospital or worse. Um, Also, you should still be getting things like your Tdap, your tetanus, diphtheria, pertussis. Whooping cough is gaining more and more of a foothold all the time in the US right now. People aren't keeping up with that vaccine, and that can be catastrophic to somebody with MS that's on one of those drugs. If you're not on a disease modifying therapy or you're on one of the oral therapies or um, one of the injectable therapies, you don't have any greater risk for a worse COVID or flu than somebody that doesn't have MS. But if you're on any of the B cell depletion drugs or Lemtrada or Mavenclad, you do have the potential to get a worse infection than you would have when you're not, when your immune system hasn't been targeted and compromised to bring down the MS activity. So yes, I do recommend that.
Thanks. Julie wrote that unfortunately, some of us did get progression from months or even years following vaccines. So she filled out the VAERS form herself and encourages others to do the same as well.
I know that my first bout of COVID, And I got COVID right at the very, very beginning in February of 2020. I had gone to a conference in DC, and my companion throughout one whole day of the conference had just come in from China 3 days before. And 5 days later, I woke at 4 o'clock in the morning feeling like there was an elephant sitting on my chest, and I couldn't stop coughing for 6 weeks. My MS was worse for months afterwards. So, yeah, it can trigger a worse response. I was also on a B cell depletion medication at that point in time. Um, my second bout of COVID wasn't until I'd had like 8 doses of vaccine under my belt, and that one cratered me. I literally for a year had long COVID. So long COVID and MS, long COVID is not kind to MS, which is one of the reasons you really need to get that vaccine so that you're not having the significant ramifications of it. Um, there aren't that many people who are actually getting the vaccine and then having problems with the vaccine, like what you mentioned, Julie. But they're in a really small minority, probably a tenth of a percent. Um, so the majority of us really need to follow those guidelines and get the vaccines.
Thank you. Um, if physical therapy is too intense for this person, what would you suggest? What type of exercise? You recommend anything in particular?
Physical therapy for somebody with MS is not the same, should never be the same as for somebody who's rehabbing from a hip or a knee replacement. You're not there to exercise, exercise, exercise. Um, they're there to target reasons why it's difficult for you to move and to give you exercises that you can do at home. And again, with MS, we're not looking at repetitions. If you've got somebody that says you need to be doing 10 repetitions of this 10 times a day, they're not an MS certified physical therapist. They need to know that increased activity like this or more intense exercise can actually be counterproductive for people with MS. It can increase spasticity rather than relieving it. And you may just need a different physical therapist. I had a episode with a new physical therapist a few years back, and he made me do the exercises that he wanted me to do fully in in the office over a 45-minute period. I was so wiped after that I got in the car to come home, and I had to pull off to the side of the road pretty quickly because I didn't recognize where I was. I'd forgotten where I was going. It was that debilitating. And I just had to crank up the air conditioner in the car and empty my water bottle, drink it down, and I put the seat back in the car and cooled off until I began to recover a little. Now, when I go to the physical therapist, if they're giving me a new exercise, I ask them to show me what they want me to do. I will do a return demonstration so that they know I've got it. And I refuse to do any exercises while I'm with the physical therapist. I'm going to them, utilizing them as a resource. What can I safely do? What should I do to correct this weakness or relieve this pain? Show me what to do, and I will do it. Physical therapy isn't just done in the office. Physical therapy is something you do under guidance, under direction, and it gets changed usually every visit when I've gone in.
Hmm, great answer. Yeah, and everybody's different, right?
Mhm.
Everybody's responds differently.
Yeah.
Okay. Do we have any more questions? I wonder. Let's see. What can we tell everybody, Sherry? Is there something coming up that we Actually, for the person that just asked the physical therapy question, Dr. Herb Karpatkin every other month does also a Q&A for an hour, and you can
Yes,
ask,
physical therapist.
yeah,
Yep.
can ask him
And
questions too.
yeah, he's got some really good tips and information to help you sort of navigate your own physical therapy and reconditioning. So, one of the things that if you didn't catch our December webinars at the end of December, I think December 22nd or December 23rd, there was a letter sent to the makers of tolobrutinib, um, telling them that the FDA could not authorize that drug, one of the BTK inhibitors. It was the closest to being approved, and we thought it was going to get approved in July, and then we thought it was going to get approved in October, and then we were pretty sure that it was going to get approved in December. And the FDA said no, it had too high a risk of liver injury, including death, and a need for transplant. So that drug has been taken out of the research pipeline. There is still another drug called fenebrutinib with another manufacturer that is in clinical trials. It is only for, let's see, it is that one has an arm for primary progressive MS. So we're hoping that we'll have another drug for primary progressive. We're still not seeing anything for secondary progressive. So if you do have secondary progressive MS, it's very possible that your neurologist will be trying you on a medication that's used for relapsing forms of MS.
Hmm. Would you
Just
recommend, I'm sorry, go ahead.
that's just to be on the safe side so that you don't get further damage. So
Yeah.
I'm sorry, would you?
No, that's a really good point. But would you recommend yoga?
Absolutely. Yoga is, as long as it's not hot yoga can be in a heated room and it raises your body temperature as well. And that's thought to relax muscles. That said, anybody that has a heat sensitivity, and that's more than 90% of us with MS, don't do well with hot yoga. But yoga is slow movements, focusing on a lot of stretches, and that helps to minimize spasticity and really get your muscles in better shape.
Okay. And Ben's asking, how do you respond to the unusual symptom treatments?
Ben, I don't know which unusual symptom treatments you're talking about. Could you clarify that for me?
We can give
I'm,
we can give him a
yeah,
minute to type it in. We'll go to the next one.
sure.
Julie said, can MS increase frequency of cardiac premature atrial contractions? I guess she takes no drugs, has been successfully toning down the PACs with deep breathing to encourage vagal nerve stimulation.
All right, Julie, I need to ask, are you seeing a cardiologist for this? Or is this self-diagnosed because you're feeling some palpitations? Um, Also, what you're describing is often a symptom of perimenopause. And so this is not generally caused by MS at all. It could be caused by hormonal changes. It could be caused by caffeine, whether it be diet sodas or Cokes, any caffeinated sodas, Mountain Dew, um, energy drinks, any of that sort of thing can cause PACs, as you're talking about. But generally, MS does not. In rare instances, if you've got some brainstem lesions, the brainstem is sort of um, the engine hub of the body. It controls the life support systems. And if you've got lesions there, occasionally we'll see somebody that, for no better explanation, we say their MS is impacting um, their heart rate or their blood pressure, um, because we don't have any other explanation for it. But you do need to be seeing a cardiologist if this is happening.
And she just wrote in, yes. Um, she says, have had the ZIO.
Have had.
ZIO. ZIO.
I'm trying to pull this up so I can see it. Um, yes, have had the ZIO. I don't know what the ZIO is, Julie. Um, but a cardiologist is what you need to be seeing for this. This is not generally MS related. It's very, very rare for somebody to have brainstem lesions that are causing that.
Okay. And in answer to your, you asked Ben to elaborate on how do you respond to the unusual symptoms. You asked him what type of unusual, and he said herbal, red light, blue,
Oh,
methylene.
okay. All right. Those aren't symptoms. Those are treatments. All right. So, herbal treatments, there is no herbal treatment that cures MS or improves MS symptoms that has been shown to do that. Red light, there are some studies that have not shown it to have any really profound impact at all on MS symptoms. Methylene blue, again, nothing. So if you're seeing people claiming that these things help MS symptoms, they generally don't. If you personally have tried something that has helped your MS symptoms, we'd love to hear that because Ben, I know you're a very credible person. You are not somebody that um, uses information that hasn't been tried and true. So my guess is that you're probably being heard or being asked these questions from members of your group or seeing them on Facebook. But we just we haven't seen any of these alternative or unusual treatments really work all that well for MS.
Okay. Um, ZIO is a heart monitor, like the Holter monitor.
Okay. All
So,
right. But again, this is, Julie, this is probably not related to MS, and I would take the guidance from your cardiologist. We need to really keep those, what we call comorbidities, things like high blood pressure, diabetes, thyroid disease, under control. The premature atrial contractions or fibrillation. Any of those things need to be kept under control, or our MS symptoms actually become more pronounced.
And she said that she's way past menopause. She doesn't consume caffeine, probably has a lack of sleep and too much stress over a long period. It impacts the rest of her MS too. So there you go. Let's see. Let's see. Someone's saying my MS physical therapist videos our session for my review, which is really
I love
cool.
that. I love that. That way,
Very cool.
you get out of the office and you'll say, wait a minute, what did he say? Or she said something about, but I don't remember what it was, and nothing is reflected on the handout they've given you. So I think that's a wonderful way to work with that.
hmm By the way, Ben mentioned that he helps moderate a large 120,000 plus Facebook group.
I
Way
knew
to
that,
go.
and I can't think of a better moderator for that. Ben, I really honor you for that and for asking those questions.
Oh,
I
nice.
see somebody from Facebook.
Yep. Let's see. Linda says, how does MS affect the stomach and bowels? Can it cause gastroparesis?
Paresis. It
Mm-hmm.
can. It can slow the motility of the bowel. Um, Again, this isn't in everyone. And oftentimes this can be very readily corrected with dietary changes. White breads and pastas are the main thing that drives this slow bowel for people. I don't recommend anyone with MS be doing pasta more than once in a blue moon, or white processed breads like Wonder or Sunbeam breads, they're just they turn to goo. They almost turn to glue in your GI tract and solidify. You've got to really have a lot of fiber to get those two items of food through your GI tract and out. Um, you need to be adding in extra fiber, preferably in your food. Fresh raw vegetables and fruits, salads, um, multi-grain breads that aren't heavily processed. I think one of the most processed foods, and I used to never think that this was a highly processed food, but white bread is one of the most highly processed foods that we consume.
Hmm.
So avoidance of that is what we need to be tending to. And gastroparesis can be triggered by MS, but again, there's a dietary component to that. You need to be seeing a gastroenterologist. You need to be following the dietary protocols with that. It's just that we tend to have a slower GI tract, particularly if we're having urinary symptoms. I mentioned this earlier, the urinary symptoms, the bowel symptoms, and oftentimes the sexual dysfunction symptoms that are coming up are all of those nerves come out of the thoracic spine and the lower thoracic spine right around T11. So if you have lesions around that area or even just above that, it could impact that. And sometimes you need a little extra help, extra tools. And I include dietary adjustments in that tool category. So yeah, those things are definitely a potential worsening because of your MS, but they do have things that you can do to help them.
Thank you. Do you have an opinion on celery juice as a reduction for inflammation?
No, I do know that celery, although it doesn't taste like a whole lot, is really good for you. It's got the fiber. Celery juice, I think, is an extremely refreshing beverage. Um, but I don't know that there's any real benefit from it.
Okay. And Trey is asking, what about acupuncture? Because their hands get numb, even heavier sometimes. So, do you have an opinion on that?
I do know that today's acupuncturists, particularly, we do have acupuncturists that have that MS certified specialist designation as well, are very aware of the nerves that are impacted by MS in many people, and they can be very, very helpful. Probably half of the people that get acupuncture for their MS symptoms find relief from it, so it's certainly worth trying.
Wonderful. So, Sabrina said, could MS cause shortness of breath with activity? She has a lesion on her brain stem and thought it was related to that. She's had a CT, chest, she's had PFTs, and they were all normal. Nothing has been found to explain the shortness of breath.
Let me tell you, you're explaining me, particularly when I was in my 40s. Before I even knew that I had MS. I've had MS myself since my first hospitalization now was in October of 1975. So I've had this for more than 50 years. And exercise caused shortness of breath in my 30s, in my 40s, certainly in my 50s. It wasn't the MS that was doing that. It was the fact that I was so out of shape. It wasn't funny. Just walking a block made me short of breath. Um, and and that is fixable with slow, steady increase in physical activity over time. It may take you several months before you get to the point where it's no longer making you short of breath. My husband and I were out walking before the holidays, before the first of the year, and I think we did a mile loop around our in-town home. And he said, "Boy, you're not even getting short of breath." And I said, "No, because I'm doing my exercises regularly. I'm walking rather than driving. If something is within, a few blocks of the house, there's a lot of different things that I do to keep active. And that's not to say that I don't get short of breath when I'm doing unusual things. Like yesterday, we were resettling a room we had remodeled. And I'll tell you, moving that 18-inch thick, queen-sized firm mattress around the corners and up onto the bed had me huffing and puffing. But that was an unusual activity. It's just a matter of being, I hate the term deconditioned, but that's exactly what it is. You're not in the condition that you are for optimal functioning, and that can be fixed with regular daily movement. Start out with movement. Don't consider it as exercise. And as I've often said, as I'm sitting here doing this, I usually try to get up and move every 10 or 15 minutes, but I'm sitting here in front of the camera and talking to you, and I'm walking underneath my desk. So I'm not sitting still, even though it may look like I'm sitting still. Those are the sorts of things that you can do just just to make things a little easier.
Mm. And I constantly talk about Herb Karpatkin because, like, I was in the pool the other day talking to people that don't have MS, and we were talking about their ailments. And I said, well, Herb Karpatkin says if you want to move it, you got to move it, right? If you want to walk, you have to walk. And when people say, is swimming okay for walking? And he says, it's great, but it's not walking, right?
Right.
If you want to walk, you have to walk. So I,
So the way that he says it's not walking. If you have been in a chair and you need to get yourself moving again, pool noodles to keep you up and walking in the water is one good way to start rebuilding that strength in your legs. So that I would consider that walking if you're transitioning from chair to the goal of walking again.
thank you, Sherry. I think we have time for one more, and we do have a question. Is it unusual for someone in their 50s to be diagnosed with MS?
Not anymore. Only because we have added to the criteria for diagnosis. For women, particularly, we are often told that our symptoms are so vague, they don't make sense. It's got to be all in our head. It's got to be a psychiatric origin. And now we have some very distinct tools that can help us to diagnose. And as doctors get more familiar with what those tools are, they're finding out, oh my God, I should have listened to her 10 years ago. She has MS. We could have done something more to help her sooner. Um, and being diagnosed at 50 is certainly not a death sentence. There's so much that can help you at this point in time. But again, it takes work. It's not just being done to you. The treatments are not being done to you. They're being done for you and with you. And primary is not just going to be a medication that's going to help you. It's going to be lifestyle changes. It's going to be moving more. It's going to be changing the way you eat, getting all those processed and preserved foods out of your diet. And that's going to be a lifelong thing. You've got to say goodbye to some of those things. Not,
Mm.
I absolutely love cherry pie, and I will occasionally bake a cherry pie, but I don't have more than like one little 1 inch wedge of it, and that's enough to satisfy the sweet tooth. And that'll be, maybe
Oh.
a couple times a year that I'll indulge in that. But I do notice oftentimes with that even little bit of sugar that my pain ramps up. So, and you'll get to know your body and its response to some of these triggers. like sugar.
I remember when I first met you, you weren't eating any sugar. You were really, really good. I don't think any gluten. You were doing, yeah,
No, no gluten, no dairy, no processed sugars. Um, But I'm
yeah.
finding that now that I'm in my 70s, I'm not as sensitive to those things. And I have a feeling that for women, particularly as we go through perimenopause and menopause, sometimes there's enough inflammation in our body from what's happening with hormones that the symptoms can become more pronounced. And maybe we respond more strongly to some things during that time in our life. And as we get through that and past that, we may be able to introduce some of those triggers back in without a real negative.
Mm. Thank you so much, Sherry. That does bring us to the end of our time. If any of you have missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Please reply to your registration email for information on how to access the recordings, or just sign up for our newsletter to learn about upcoming events. Our next teleconference will be this coming Monday, February 2nd, and it's going to be at 7 o'clock p.m. Eastern Time. And we're going to have Tiffany Malone presenting. We had a series that she did in 2025 on mental health. This is a continuation. We're going into 2026. The title is Mental Health Matters: The Power of Possibility and the Permission to Change. Should be really good. As you leave the conference today, a survey will appear on your screen. We'd ask that you just take one moment to fill it out, because with your answers and your opinions, it's going to help us get the best programming to you. So our sincere thanks to all of our attendees for your participation today, and especially to Cherie Binns, who spends so much time constantly helping the foundation and the MS community in general. So enjoy the rest of your day, everybody, and we hope to see you next time. Thanks for coming.
Thank
Bye.
you. Bye, everyone.